So much for that introduction, Angela. And thanks to the seminar organizers for the invitation. I'm really happy to be here and get the chance to present to you guys in person, and those of you on Zoom. I'm really going to do my best to work the room, so I'll get like an oblique workout from twisting. Today I'm going to be presenting findings from a recently completed paper. It's titled Flooding, Sociospatial Risks and Population Health. So I'm going to dive right in because I think I have between 30 and 40 minutes. So it will be no surprise to folks in the room that a large body of literature across a diverse set of social science fields has amassed on the population health consequences of severe floods and other hydrological hazards. So severe flooding, we know, can affect physical health problems through direct injuries, exposure to contaminated water, increase the risk of communicable and infectious diseases, and also result in stress that can lead to somatic type of complaints like back problems, stomach problems, headaches, and migraines. Scholars of mental health have also found that disaster-related trauma, often linked with flood exposure, like fear for your safety, not knowing the safety of your loved ones, as well as material losses, can be linked to increased risks of post-traumatic stress disorders or symptoms, depression, anxiety, and a range of other mental health problems. We also know that these are often compounded by secondary stressors, like a reduction in lack of access to regular medical care or healthcare facilities, household disputes that occur in the stress of after a disaster, as well as job disruptions. So in this paper, I'm going to focus attention on one disaster in particular, which is Hurricane Harvey. It was a tropical storm that occurred in Houston, Texas in 2017. Houston at the time was the fourth largest city in the United States. Now it's the fifth largest city. It happened in August 2017. It was a Category 4 storm that caused catastrophic flooding, 125 deaths, and it was the costliest disaster in US history, tied with Hurricane Katrina, causing around $125 billion in damage. The map on the left is showing you in regular time intervals Harvey's path, which developed on August 12th, went through the Yucatan Peninsula before landing directly on Houston, Texas in late August, and then dissipated into the American mainland in September 1st. And then on the right is showing you just one of the aerial images captured in the immediate aftermath of the storm. This is the Memorial neighborhood of Houston, which is about 10 kilometers west of Rice University. And so I had to put these poll questions together. So here's our first poll question, which was Hurricane Harvey, one of the most devastating hurricanes in US history, caused widespread damage in 2017. What was the primary reason for this catastrophic impact? This is for me to gauge your general assessment of, or your knowledge. So high wind speeds that exceeded 200 miles per hour, a record-breaking storm surge along the coast, prolonged heavy rainfall that caused flooding, or a sudden shift in its path that resulted in severity. I'll move this here. You can see them kind of rolling in for those. Wow, are there 37 people on Zoom? Oh. Okay, tremendous. So the reason that Harvey was so devastating was because of prolonged heavy rainfall. Essentially, as soon as the tropical storm reached land in Texas, it stalled. And so for around 2 days straight, there was catastrophic flooding, around 48 inches of flood water. It wasn't necessarily a shift in its path or a storm surge or wind that caused a lot of the damage. It was the storm that just stalled and dumped water on the city. So given this large body of evidence on the physical and mental health consequences of disasters, this research is not perfect, and there's room for development in both empirical and conceptual ways. So the bulk of work in the Canadian and US context, so outside of developing context, I would argue, on flood exposure and health outcomes suffers from several empirical limitations frequently that have limited our ability to identify comparable control groups and to generate more credible estimates for how much of population health is affected directly caused by the disaster and not confounded by other unobservable characteristics or selection effects. So the bulk of existing evidence on non-hospital health morbidities from floods in the United States, for example, is associational and tends to rely on non-representative samples that are often collected after the disaster occurs. This makes it pretty difficult to assess both the internal validity of the exposure health relationship, as well as the external validity of the generalizability to the target population, the people who are exposed to the flood. So the potential risk of bias in this context, especially in disasters in the United States and Canada, are really quite serious because we know that flooding is not random. It doesn't randomly happen, but it rather occurs, especially in the United States, patterned along race, class lines, observable characteristics about populations that we also know matter for their health. So because flooding is not random, we want to be really attentive to the extent to which selection effects are happening in our empirical models. Beyond these empirical reasons, there are also conceptual ways that I think we can develop and that I aim to in this paper, our understanding of floods and population health. So existing conceptual models of disaster health risk distinguish between social forms of vulnerabilities like poverty, minority race, female sex, older age, and they distinguish those from spatial forms of vulnerability like proximity to the coast or the topography of the area in which you live. However, in this paper, I argue that similar to the social processes that undergird sociodemographic variability and social vulnerability, like economic practices, institutional arrangements, fundamentally social mechanisms also determine which places are spatially determined to be at risk. So that is, risks and vulnerabilities commonly defined by scholars as spatial, like residing along a sloped valley for wildfire risk or in a floodplain, are not entirely spatial. There is an objective spatial dimension to them, but there are also social processes embedded into which areas we deem at risk of a wildfire or a flood. These are related to the cartography of risk mapping that policymakers often undertake in delimiting which areas are in a floodplain versus out of floodplain, or which area in the wildfire-urban interface are at risk. They come through policies that promote or demote resilience and public dissemination of information to residents through various forms of risk instruments. These are fundamentally social in nature, even if they are related to objectively spatial dimensions. In terms of floods in the United States, scholars have elucidated the quite fraught and outdated nature of the floodplain maps produced by FEMA, the Federal Emergency Management Agency. FEMA creates flood maps that identifies risks and then prices that risk based on spatial proximity and topography associated with flood probabilities. Most of these flood maps are severely outdated, including those that were in Houston in 2017 at the time of Harvey. So this is just one example of what I call sociospatial determinants of risk and vulnerability. And moreover, this is important conceptually to pay attention to because as climate change exacerbates extreme weather events and as population growth, changes in land use, the increase in impervious urban infrastructure leads to flooding outside of areas historically considered at risk, new forms of risk and vulnerability may emerge as a function of these changes. So this became very obvious in the case of this disaster, Hurricane Harvey. For example, the New York Times, these are both images from the New York Times, reported the extent of the flood damage that occurred outside of the floodplains in Houston. So the headline really summarizes it, which is water damage from Hurricane Harvey extended far beyond the flood zones. The dark red dots on the map on the right are showing you a flooded building outside of the flood zone, whereas the pink dots are showing you buildings that were damaged within the flood zones. The map on the left is just zooming in on the Addicks Reservoir, which is in Western Houston, and showing you that a lot of the damage that happened in these surrounding communities were not solely those in the floodplain, but actually extended beyond the areas that the Federal Emergency Management had dictated were at risk of flooding. So, second poll question. What percentage of properties damaged by Hurricane Harvey do you think were outside of these federally regulated flood zones? Do you think it's between 1 to 20%, 21 to 40, 41 to 60, 61 to 80, or 81 to 100%? I'm seeing some consensus around 41 to 60. Assuming some type of normal distribution, that's a pretty solid guess. If buildings were randomly assigned. Okay, fabulous. I wasn't sure if I'm supposed to be asking those of you in the room. I assume you're doing it in your head. So the correct answer, 9 of you guessed it correctly. 65% of the damage to property buildings in Houston, Texas because of Hurricane Harvey occurred outside of those federally designated floodplains. So given this empirical limitation, we don't have a lot of good credible causal estimates that use representative samples to generate an understanding of the disaster-health relationship. And given existing conceptual limitations, how do we think about the fact that there are these spatial vulnerabilities that are not entirely spatial, but that there are social mechanisms that are undergirding their effects? I'm going to ask these 2 research questions. First, simply as a causal statement, I'm going to ask, what was the effect of flooding due to Hurricane Harvey on mental and physical health in Houston, Texas? And then I'm going to ask, how did the health consequences of flood exposure differ for people who were living inside of floodplains compared to observably similar people who were living just outside of the floodplains? And that's going to be my sort of sociospatial dimension of vulnerability. To address these questions, I'm going to marshal 3 primary sources of data. The first are health survey data from the Health of Houston survey. So these are individual level health and survey data that come from the Institute for Health Policy at the University of Texas School of Public Health. The HHS adult sample is representative of Harris County and the City of Houston's non-institutionalized adult population. The study began in May 2017 and was interrupted by Hurricane Harvey on August 27th, 2017. So 5 days before the storm, they stopped collecting responses. It resumed 6 months after the disaster in February 2018 and concluded in April 2018. The total sample is around 5,300 adults, including 2,500 who were interviewed before the disaster and around 2,800 different adults who were interviewed after the disaster. Because the unique opportunity that the interruption of Hurricane Harvey presented, the HHS team, of which I was not a part of, revised the sampling strategy and construction of population weights in order to allow researchers to have access to 2 repeated representative cross-sections of Houston adults. One cross-section representative of this 2017 population, and one representative cross-section of the 2018 adult population in Houston. The survey included information on the zip code of residents in the pre-Harvey sample, and then among those interviewed after Harvey, they asked both about their current residential location as well as the residential location they lived in at the time of Hurricane Harvey in August 2017. So here's zip codes, which are different than postal codes here in Canada, are going to be used as the indicator of residential location. We're going to think about these as kind of communities or neighborhoods, although they are, to be totally transparent, a little bit bigger than what we would actually think of as a neighborhood. The second form of data, outcomes of interest. I'm going to use 4 indicators of health that were asked of all 5,300 respondents. I'm going to use an indicator using the Kessler-6 score of psychological distress, which asks a series of questions about the last 30 days, how often you felt depressed that nothing could cheer you up, how often you felt anxious. Some of you maybe are familiar with the Kessler-6 scale. This is going to be dichotomized using standard thresholds that researchers have validated against known mental health morbidities to create an indicator of psychological distress. From the Behavioral Risk Factor Surveillance Survey, I'm going to use an indicator of the frequency of the number of days in the last month that your mental health was poor. This is a commonly used question in health surveys, especially in the United States. I use one for mental health days as one is for poor physical health days. And then I also construct an indicator that we're all, or I assume many of us are very well familiar with, which is an indicator of the probability of having fair or poor self-rated health. I'm going to think about the former as indicators of like severity and the latter as indicators of like frequency of ill health. Okay, second form of data I'm going to use is to estimate flood exposure and to construct treatment and control groups. So I'm going to use local estimates of flood damage, or I'm going to create local estimates of flood damage at the zip code level on 156 zip codes where respondents were living in the city of Houston. So to construct the zip code level estimates of flood damage, I combine 2 sources of data. First, I estimate local flooding from FEMA's Harvey flood depth maps, which estimate 1 foot of flooding using satellite imaging from August 28th to September 1st. So I calculate the total of 3 meter by 3 meter pixels in a zip code that were flooded with at least 1 foot of water and divide that by the overall land area in the zip code. For the amount of property damage in a zip code, I construct an estimate of the value of flooded property using several sources. I gather from the National Flood Insurance Program the total number of claims made for flood damage in each zip code. I use data from FEMA's Individuals and Households Program around the number of the amount of claims made for flood damage. And then I also use data from the Texas Department of Insurance that includes the non-federally, so private flood insurance payouts that were made from the Texas Department of Insurance. I'm going to aggregate and sum the total of property damage claims and then divide that by the estimated value of property from the most recent census estimates. Just using the numerator of that would statistically treat higher income or wealthier neighborhoods as more damaged because there's more property value to have been damaged in the first place. So I'm going to index that to the estimate of how much all of the housing is essentially worth in that neighborhood in order to adjust for that potential bias. So using these 2 zip code level variables, I construct a sum score and to measure flood damage. And I construct a treatment group defined as the 40 most flood affected zip codes. On average, these zip codes had 69% of their land area covered by at least 1 foot of water. And on average, they experienced $119 million in property damage. These descriptive maps show you the construction of the treatment group. Panel A shows the correlations between the land area flooded on the x-axis and the scaled property damage estimate on the y-axis. The flooded treatment group are the non-contiguous areas in Houston in panel B, and that shows you the 40 most inundated zip codes in the dark blue color, and what's going to become the control zip codes are in the lighter blue color. Finally, to assess sociospatial vulnerability associated with the floodplain coverage, I overlay FEMA's floodplain maps onto zip code boundaries and estimate the proportion of land area in each zip code that was considered at risk of a 1 in 100 year flood. This variable has a mean of around 17% of land area and standard deviation of 15%. And for this indicator, I'm going to dichotomize it by identifying the 20 zip codes with the highest floodplain coverage. And I selected this threshold because it meant that in the high floodplain coverage neighborhoods, on average, 50% of the land was in a floodplain. This is showing you the individual FEMA 1% floodplain, that's 1 in 100 on the left. And this is showing you aggregated up to the land area. The zip codes identified in or outlined in red are those that are deemed in this analysis as high floodplain coverage. So these are communities that are deemed high spatially at risk. So to statistically estimate the effect of flooding on population health, I'm going to use a difference in differences estimator, which exploits that geographic variation in severity of flood damage, and as well as temporal variation in the pre to post Harvey sampling frame. So specifically, I'm going to model health outcomes, some Y, for each adult I and zip code J, which corresponds to their treatment group G, with this equation. So a dummy variable for F indicates the flooded treatment group. A dummy variable for T indicates the post-Harvey sample. This vector X after beta K is a series of individual level controls, including known sociodemographic characteristics that matter for population health. The coefficient of interest in this model is beta 3. It represents the difference in difference estimates by interacting that dummy indicator for treatment group and the post-Harvey dummy indicator. It can be interpreted as a comparison of the pre to post-Harvey changes in health in those living in severely flooded neighborhoods with the pre to post-Harvey changes for people living outside of those severely flooded neighborhoods. The identifying assumption for this model to estimate a causal effect, an average treatment effect on the treated, so just among those in the flood zones, is that changes in population health from before to after Harvey would have followed the exact same path if Harvey would not have had occurred. I also use a second difference in differences equation that rather than using just a dummy indicator for living in a flooded treatment zone, it's going to add this zip code fixed effects, which is going to absorb all of the within Houston across zip code variation in zip codes. And this beta 3 is still going to be the coefficient of interest in this model. Results are going to be substantively similar no matter which way I define it. I then estimate what's called a triple differences equation to test the extent to which the health effects of flood exposure varied by the level of floodplain coverage. In this model, beta 7 represents the triple differences estimator. The coefficient examines whether the health of residents who lived in areas that flooded and were in floodplains changed after Hurricane Harvey after netting out the pre to post Harvey changes in health among unaffected communities that had little to no floodplain coverage. The identifying assumption in this equation is that the health of those living in severely impacted communities across every level of floodplain coverage would have followed, again, a common path to the health of those in severely impacted communities across floodplain coverage had Harvey not had happened. In order to use these equations to generate average treatment effects among the treated, to estimate the average health effects of flood exposure among those living in flooded communities, there are going to be several threats that I'm going to address to this research design. The first is divergent trends, then compositional differences. If the actual people who live in these different types of communities are different, that can confound that effect. And also spillover contamination. If people are, after Hurricane Harvey, moved to a bunch of different places, such that when we interview them after the storm, they're no longer in the communities that they were, that will also cause issues. So in order to check for parallel trends, I'm going to do kind of like a quasi-placebo check. Essentially, I'm going to restrict my data solely to the pre-Harvey sample, and I'm going to pretend that Hurricane Harvey happened every single day from the third day of interviewing in June all the way to just before they stopped interviewing before the disaster happened in 2017. So, and these placebo difference in differences estimates should all be null, because in the absence of null, especially in the absence of a change in the trend, that suggests that in the summer before Hurricane Harvey, the health of people in communities that were about to be flooded really badly was changing differently than the health of people who were living in communities that were not about to be badly affected. So this is providing evidence. All of the placebo estimates are null, suggesting that before Hurricane Harvey, there were no divergent trends in the health of residents that were about to be severely affected compared to those that were not affected. I'm just showing you these two for the probability of distress and probability for fair or poor self-rated health. Second, to ensure that the treatment and control groups, those living in flooded and unaffected communities, are comparable across time, I'm going to use a weighting scheme, inverse probability of treatment weights in all regression equations. In brief, these ensure that we construct time by treatment groups that are statistically similar to one another on a set of observable characteristics that I, as the analyst, have decided the equation needs. So I'm going to do this both for the difference in differences and then again for the triple differences analysis. These plots show you the result of that weighting scheme. And essentially what they're showing you is that after we apply this weighting scheme along sex, age, race, poverty status, household size, home ownership, foreign born, single, never married, no health insurance, a bachelor's or above, that the treatment and control group before and after Harvey are statistically similar to one another. So we can rule out by applying these weights that there's a large risk of bias in our models coming from compositional differences in these communities or in the sampled respondents that I'm using to construct these communities. Moreover, this weighting strategy also results in treatment and control groups pre and post Harvey that are statistically similar to those estimated from the American Community Survey or from census estimates. This means that using this strategy, we've also retained the population weighted or population representativeness of the sampled frame, given the known observable characteristics about the 900,000 people who lived in these zip codes. Finally, I ensure no spillovers from the post-Harvey survey. As I said before, I use the zip code at the time of Harvey. I also include robustness checks that I'm not going to show you, so you just have to trust me or read the paper when it comes out next month, that it is robust to excluding people who left, and also robust to the inclusion of a spatially lagged independent variable that assigns treatment both based on where you live as well as the neighborhood or the zip code adjacent to you. So let's get to results. So here are the results from the difference in differences estimator. I'm displaying average marginal effects. I'm holding all other variables at their means for the days of poor mental health and the days of poor physical health. And then for distress and fair or poor self-rated health, I'm showing you estimates from a linear probability model. For the difference in difference estimators, using changes in the control group as the counterfactual, I find that flooding led to a 7.6 percentage point increase in the probability of psychological distress, 1.43 additional monthly days of unhealthy mental health, and an 8.5 percentage point increase in the probability of fair or poor self-rated health. Note that these estimates are not small in magnitude. For example, the prevalence of psychological distress in the flooded group was 0.193, 19.3%, meaning that Hurricane Harvey flooding led to a 40% relative increase. That's not small in magnitude, and especially when we scale to a population, that's pretty meaningful. This row is showing you exactly the same estimates I just showed you. The second row is showing you the difference in differences estimate when I include the zip code fixed effects, the second model that I told you about. And what I show here is that the findings on the probability of psychological distress and fair or poor self-rated health reduce in magnitude a little, but are nevertheless statistically robust, whereas the effect on the mental days of poor mental health is not robust to adjusting for across zip code heterogeneity. Finally, I'm going to show you, this row shows you estimates if we pretended like we had no information about the population health before Hurricane Harvey. As we often do, researchers would go out after the disaster, survey 2,500 people, and then estimate the effect of the flood. And this is what this is exactly showing you. So I'm ignoring the pre-Harvey treatment group. I'm not doing any of the statistical techniques I just talked to you about around weighting and around specifying that counterfactual. And this is what that would have showed you. If we just relied on the post-Harvey sample, we would have concluded that distress increased by 10 percentage points, days of poor mental health increased by 1.48 days, etc. So what this is showing you is that by unaccounting for the pre-Harvey population distribution and population health distribution, we would have overestimated these effects. So this is just providing some assurance that this strategy is actually pretty important if we really want to generate credible, internally valid and externally valid causal estimates of the effect of flooding on population health. Finally, I'm about to show you the results of did flooding affect health worse in places that were inside versus outside of floodplain coverage? Before I do that, who do you expect to have experienced the worst health outcomes as a result of exposure to flood damage? All else equal. So, because I've just showed you that all else is, in theory, equal. Do you think it's people living inside of flood zones, people living outside of flood zones, or do you think there are no statistically different impacts of flood exposure? Oh, I love this. We've got some differences in guesses. I should have added an option D, which is you don't believe any of my modeling strategy. Oh, this is tremendous. Okay. So the correct answer is that people living outside of flood zones experienced worse health outcomes as a result of exposure to flooding. So these results are showing you the triple difference estimates. It's a lot to see, so I'm just going to focus on the post-Harvey flooded floodplain interaction. So the coefficients on the post-Harvey flooded variable shows the health effects of flooding for those outside of floodplains, which were significant for both mental health variables. The triple difference estimates, the pre to post-Harvey change in the probability of distress among people who were exposed to flooding was 152 percentage points lower in the high floodplain coverage group relative to the changes experienced among those outside of floodplains, but also severely flooded. The triple difference estimates on monthly unhealthy mental health days was 3.85 days fewer. And the effects on physical health were not statistically different from zero. So we cannot reject a null no effect. So instead, I'm finding that people living outside of floodplain coverages, or people who experienced flooding but lived outside of floodplains, experience worse mental health outcomes in particular. And that's because this negative effect is estimating it for people who are living in the floodplains. As you realized, I have dichotomized my independent variables, or my treatment variables, floodplain coverage as well as flood severity, but these are otherwise continuous measures. It was the amount of property damage and the amount of flooding and the proportion of the land area in your neighborhood that was covered by a floodplain. So here, I'm showing you results from a triple difference models that uses continuous measures. So on the x-axis, it's the continuous flooding score as a z-score. So still that summed measure of flooding and a flood inundation and property damage. But instead of dichotomizing it to the 40 most inundated zip codes, it's just the z-score. And on the y-axis, I'm showing you the proportion of land area in a floodplain. And this is the triple difference estimate using those continuous measures. The two-panel contour plots show the predicted probability of psychological distress. So one of the mental health outcomes that I found was significantly greater for people living outside of floodplains when exposed to flooding. The darker red colors represent greater levels of psychological distress. Each black dot represents a respondent, so they're clustered around their assigned X and Y value at the zip code level. The two-panel contour plot illustrates the interaction between flood severity as a z-score on the x-axis and floodplain coverage on the y-axis on psychological distress before Hurricane Harvey on the left and after Hurricane Harvey on the right. In the left panel, we see that before Hurricane Harvey, there was no notable association between the interaction of flood severity and floodplain coverage on the probability of psychological distress, adjusting for observable characteristics of people. This indicates that prior to Harvey, psychological distress levels were pretty stable after we adjust for race, class, and all of the other X in that vector that I showed you. However, in contrast, the right panel reveals significant change in this pattern. Focusing on communities with flood inundation scores above 1 standard deviation, the mean, for example, on the x-axis, we observe a gradient along the y-axis. Specifically, individuals in areas with low floodplain coverage, so lower on the y-axis, experienced a greater probability of psychological distress compared to those in communities with higher floodplain coverage, but the same amount of flooding score. This is what this map is showing you. To understand why the mental health consequences of flooding were greater for people living outside of floodplains, I conducted a descriptive analysis of mechanisms. So these are not causal claims. I'm relying here on either the pre or post-Harvey sample. In the post-Harvey sample, they asked a series of questions in the HHS around whether or not you lost your income because of Hurricane Harvey, whether or not your home was damaged, whether or not you evacuated or had to evacuate, and whether or not you had What I'm showing you here is that people who lived in a floodplain, adjusting for controls and using survey weights, were marginally significantly more likely to experience home damage, which we would predict reduces their health on average. However, they were much more likely to evacuate out of harm's way, and they were much more likely to have plans or supplies in place compared to their counterparts who lived outside of floodplains. So I'm going to argue, or I'm going to suggest that this is evidence that some of the types of information and the types of preparatory procedures and the types of risk awareness that comes from living in a spatially vulnerable place like a floodplain also endows residents with some strategies to avoid some of the physical health and mental health, well, mental health in particular, problems associated with exposure to severe flooding. If you got out of harm's way because you knew you lived in a floodplain and it was time to get out, versus people who lived outside of floodplains and thought, it's not going to happen to me, and then it did, and they were left experiencing the consequences. As with all and every empirical paper that I ever write and that you will ever write, there are many limitations to consider. The first is that, unfortunately, the Health of Houston survey did not ask a question about flood insurance. I condition my models based on known correlates of flood insurance uptake, like race, age, insofar as white non-Hispanics in the United States tend to have flood insurance compared to their other counterparts. Older people tend to have flood insurance compared to their counterparts. Higher educated people tend to have flood insurance, and also people who are higher SES. Although I can't rule out that that was playing a process and may dampen some of the detected effects. Finally, I only observed people who were in Houston. That is, I didn't follow people who were living in Houston at the time of Hurricane Harvey and then left Houston to go elsewhere, maybe to San Antonio or Dallas, and then they didn't return 6 months later. This may lead to bias, but it may lead to bias in opposite direction. It may mean that I have overestimated the effects of flooding on health, or it may mean that I've underestimated the effects of flooding on health. I'm going to argue, based on the empirical research that I've read from other disasters, that my estimates likely understate the true effect because those displaced outside of Houston probably were suffering from worse health. It would operate in the opposite direction if you hypothesize that people who left Houston were healthier than people who stayed in Houston. So if that's your hypothesis, then what I've just shown you is going to overstate the effects of flooding on population. So in conclusion, and I think I'm doing decent on, 39. I was told 30 to 40. I'm going 40. Harvey-related flooding, I'm going to argue, I'm going to stick my neck out and make causal claims, not associational. Harvey-related flooding caused increases in psychological distress and poor health. but potentially less so than suggested by prior work due to a function of selection into neighborhoods vulnerable of flooding, as well as potentially sampling bias from non-representative samples of Houstonians. The adverse effect of flooding on mental health was greater for adults living in communities with less floodplain coverage compared to similar adults living in communities that experience similar levels of flooding, but they happen to live inside the floodplain. And finally, based on some of the descriptive analysis in my conceptual framework, I'm going to suggest that sociospatial forms of vulnerability can stratify health adversity after disasters. And this serves to reify the known link between residential location and population health. And for future research on disasters in the era of climate change, this matters, I think, a lot, targeting resources effectively and ensuring health equity in major US cities and Canadian cities. So with that, I will open it up to questions. The paper is forthcoming in Demography next month. I'm very grateful to funding support from the now non-existent Peter Wall Institute for Advanced Studies, and I received lots of helpful conversations. So thank you guys for listening, and thank you on Zoom.